Right now, as you watch this, someone on Earth just had a stroke. It happens every 40 seconds. No warning, no countdown, no second chance. Every single year, nearly 6 million people die from stroke. Millions more survive but wake up unable to move half their body, unable to form a single word, or unable to recognize the faces of the people they love most. And here is the part that will stay with you long after this video ends. In the majority of cases, the brain does not go silent without warning. It speaks. It sends signals hours, sometimes days before the catastrophic event. Signals that are specific, recognizable, and completely actionable, if you know what you are looking for. In this video, you are going to learn the 5 warning signs your brain uses to tell you a stroke is coming, why your blood vessels start failing long before any symptom appears, 3 medical tests that can catch the danger before it is too late, and exactly what to do in the critical 72-hour window that can determine whether you walk away from this or not. Before we get into all of that, my name is Dr. Vanse. I work in medicine because I believe that people make better decisions when they actually understand what is happening inside their own bodies. That is the only reason this channel exists. If that is the kind of content you want more of, hit that subscribe button right now and tap the bell icon so you never miss a new video. This channel is built for people who want real health information explained clearly, without the drama and without the sugarcoating. And if that is you, you are in the right place. Let me start with something that most people get wrong. When we say stroke, we are actually describing 2 completely different emergencies. In a hemorrhagic stroke, a blood vessel inside the brain tears open. Blood floods the surrounding tissue, forms a clot, and begins compressing the brain from the inside. Many of those patients do not survive. The second type is an ischemic stroke. Here, the vessel does not rupture, it gets blocked. Blood flow to part of the brain stops, and within 4 to 6 minutes, the cells in that zone begin to die in ways that are permanent and irreversible. Ischemic strokes account for roughly 85% of all strokes, so that is the one we're going to focus on today. To understand why speed matters so much, you need to appreciate how demanding your brain really is. It weighs about 3 pounds, barely 2% of your body weight, but it consumes around 20% of the oxygen you breathe and roughly 25% of all the glucose circulating in your blood. It never shuts off. It needs a continuous, uninterrupted fuel line every second of every day. Pull that fuel line for even a few minutes, and cells die in ways that cannot be undone. That is the biological reality behind the phrase that every stroke specialist uses: time is brain. Here is what most people never hear. For a brain artery to suddenly block, the groundwork was usually laid over years. The inner walls of the vessel had been quietly degrading. Fatty deposits had been building up. The opening through which blood travels had been getting tighter and tighter. A stroke is almost never an explosion out of nowhere. It is the final step of a long, slow process, and along that road, your body gives you warnings. The problem is that almost no one ever taught you how to read them. In medicine, these warnings have a name. They are called transient ischemic attacks, or TIAs. The word transient simply means temporary. The symptom comes, and then it goes. Picture one of the major arteries in your neck, the one that carries blood from your heart up to your brain. Over years, a fatty plaque has built up on the inner wall right where the artery branches. The opening has narrowed. Then one day the already tight vessel goes into a brief spasm. Blood flow stops for seconds or a few minutes, and the part of the brain fed by that artery essentially blacks out for that short window. You feel a symptom, and then the spasm releases, blood returns, and the symptom vanishes. You think you are fine again. Research is clear on what comes next. A transient ischemic attack very often precedes a major stroke, typically within the following 72 hours. Those 3 days are your window. That is still the period where a disaster can be stopped. Most people waste that window because the warning episode was brief and strange and then went away on its own, so they talk themselves out of doing anything about it. These episodes usually last somewhere between 30 seconds and 10 minutes. Short enough to slip right through the cracks, long enough to be your brain's final, unmistakable message that something is seriously wrong. The first warning sign is temporary blindness in one eye. You are going about your day and suddenly one eye goes dark or foggy, like someone pulled a black curtain down over it, or smeared the lens with gray. You blink. You rub the eye. Within seconds or a minute, the vision comes back. So you blame it on standing up too fast or too much screen time and you move on. What actually happened is this. A tiny clot or a small fragment of plaque broke away from the wall of your carotid artery, traveled upward, and briefly plugged the artery that supplies blood to that eye. The artery feeding your eye is a direct branch of the internal carotid artery, the same artery that feeds your brain. When blood flow to the retina stops, you see darkness. When the clot drifts free and circulation returns, the vision comes back. You feel relieved. But that same clot, 2 millimeters in a different direction, would have gone into a brain artery instead. And instead of a 60-second blackout in one eye, you would be facing permanent loss of speech, paralysis of an arm and leg, or death. Neurologists treat a description of this episode the way firefighters treat a smoke alarm. The Latin term for it is amaurosis fugax, fleeting blindness, and it triggers urgent evaluation every single time. The second warning sign is sudden numbness or tingling on one side of your body. It can be the whole arm, just the hand, half the face, or one full side of the body from head to foot. It feels like pins and needles, like cotton under the skin, or like that body part has gone completely rubbery. The critical detail is that it arrives out of nowhere while you are simply sitting, walking, or talking, and it resolves on its own after a few minutes. You have probably experienced numbness from sleeping on your arm the wrong way. That is entirely different. In that case, you compressed a nerve, and as soon as blood flow and position normalize, sensation returns. With a TIA, the problem is not in the arm at all. It is in the area of the brain responsible for processing sensation from that arm, and posture has nothing to do with it. One additional thing worth knowing: stroke symptoms are almost always one-sided. Each hemisphere of your brain controls and receives sensation from the opposite side of your body. When both hands go numb at the same time, that typically points to a spine issue. But a sudden, isolated, one-sided numbness that clears after a few minutes is a strong reason to get checked. The third warning sign is a sudden loss of coordination, what people describe as walking drunk without a single drink. You are on flat, familiar ground, and out of nowhere your foot lands wrong. Your leg feels weak or rubbery. You stagger into a wall. Or you are hit with a powerful spinning sensation that makes you grab a chair, even though nothing moved and you did not jerk your head. The part of your brain responsible for balance and smooth coordinated movement is called the cerebellum. It sits at the back and base of your skull, and it is constantly calculating where your body is in space and how hard each muscle needs to fire. Its blood supply comes through arteries that run up through the bones of your neck, what doctors call the vertebro-basilar system. If flow through those arteries drops sharply, even briefly, the cerebellum glitches. That is when you veer sideways, misstep, or experience violent dizziness with no obvious cause. Most people write these episodes off as bad shoes, tiredness, or blood pressure. Spontaneous intense dizziness combined with any trouble walking in a straight line should be treated as a possible TIA until a doctor rules out a vascular cause. The fourth warning sign lives in your speech. Let me be clear about what we are not talking about. If you occasionally cannot remember your neighbor's name or temporarily forget the word for something, that is a completely normal tip of the tongue moment that happens more often when you are tired or stressed. That is not a stroke sign. What concerns neurologists is something far more sudden and far more severe, when your speech breaks down badly enough that even you know something is seriously wrong. There are two main speech centers in the brain, both typically located in the left hemisphere. One helps you form words and send instructions to the muscles of your tongue, lips, and jaw. When that region loses blood flow, you may understand everything being said to you, you may know exactly what you want to answer, but you cannot get the words out. They come out slurred, chopped, or stuck completely. The other center helps you understand language and organize your sentences so they make sense. When that zone is threatened, a person may speak in what sounds like full sentences but produce complete nonsense, word salad that neither they nor anyone else can follow. If either of those speech problems appears suddenly and then fades after a few minutes, that is a TIA until proven otherwise. You cannot dismiss a speech breakdown just because it corrected itself. That is like your smoke alarm going off, then stopping, and you deciding it was probably nothing. The fifth warning sign is one that surprises most people, a combination of a skin condition called vitiligo alongside new, unusually strong headaches that do not fit your usual pattern. Vitiligo produces patches of pale or completely white skin where pigment-producing cells have stopped working. It develops because the immune system turns against those cells as though they were foreign tissue. And when the immune system goes off target like that, It rarely limits itself to one organ. That same autoimmune process can quietly inflame the inner lining of blood vessels throughout the body. That inner lining, the endothelium, is a microscopically thin layer of cells coating the inside of every artery. When it is healthy, blood components flow past without sticking. When it is damaged by inflammation, it becomes rough and scarred, and things start to cling: cholesterol, platelets, inflammatory proteins, all of it building slowly into the plaques and clots that narrow and ultimately block your arteries. Vitiligo alone does not mean a stroke is inevitable. But vitiligo combined with headaches that are changing in character or intensity is a combination that deserves a proper vascular evaluation rather than a wait-and-see approach. Now let me talk about what actually destroys your blood vessels from the inside, because this is where some of the biggest myths live. The most common one is this: my cholesterol is normal, so I am safe from stroke. Stroke risk is not only about what is circulating in your blood. It is very much about the physical condition of that endothelial lining. The first major enemy of the endothelium is chronically elevated blood sugar. Glucose is your cell's fuel, but it needs insulin to cross from the bloodstream into those endothelial cells. When your body does not produce enough insulin, or when your cells have become resistant to it, you can have plenty of sugar in your blood while the vessel lining is literally being starved. Starved cells lose their structure. They can peel off the inner surface and leave behind rough, scar-like patches. Those scarred patches lose their flexibility. Doctors call this a loss of vasomotor reserve, and they become perfect landing pads for low-density lipoproteins, platelets, and other blood components. Over time, these deposits build into the plaques that narrow and stiffen your arteries. This process starts years before anyone officially tells you that you have diabetes. Even mild prediabetes, where your glucose is only slightly above normal, quietly damages the endothelium for a long time before anyone notices. The second major vascular enemy is smoking. Cigarette smoke contains thousands of chemicals, dozens of which are known carcinogens. But for stroke specifically, the damage comes from what those compounds do to the endothelium and to the blood itself. With every cigarette, toxic chemicals strike the inner surface of your vessels and trigger direct chemical damage and inflammation. Nicotine and carbon monoxide simultaneously make your blood thicker and stickier, increasing how readily platelets clump together and how easily clots form. Put a damaged, inflamed vessel wall together with thick, sticky blood, and you have created ideal conditions for a clot to lodge in a brain artery. Smokers carry roughly 2 to 4 times the ischemic stroke risk of non-smokers with otherwise similar cholesterol and blood pressure numbers. Blood pressure adds another layer of misunderstanding. Many people have been told that stroke comes from high blood pressure, so they feel terrified of a high reading and relieved when the number is low or normal. Chronically high blood pressure, hypertension, absolutely is one of the strongest risk factors for stroke because over years it physically stresses and weakens vessel walls and accelerates plaque formation. It is also the primary driver of hemorrhagic strokes, where a vessel bursts. But here is a twist most people do not know. An ischemic stroke often happens not at the peak of blood pressure, but at a relative low point. Picture a brain artery already narrowed by more than half because of plaque. As long as the pressure in the system is high enough, blood still squeezes through that tight segment. But if the overall pressure drops, flow through the narrowed point can fall to nearly zero, especially if a small clot gets stuck there and the system no longer has enough push to move it. At night, blood pressure naturally falls by roughly 15 to 20%. That nighttime dip, completely normal in a healthy person, can turn a partial blockage into a full stop in someone with a plaque-narrowed artery. That is one reason people go to bed feeling perfectly fine and wake up with stroke symptoms, or someone finds them that way in the morning. Age matters, but not in the simple way most people assume. Stroke risk does rise significantly after about 50 and roughly doubles with each additional decade. In older adults, the dominant causes tend to be atherosclerosis, long-standing high blood pressure, and heart rhythm problems. But about 10 to 15% of strokes occur in people under 45. In younger patients, the patterns are different. Congenital vessel abnormalities, aneurysms, clotting disorders, autoimmune conditions, and trauma to the head or neck all play a larger role. After about 40, plaque buildup and endothelial injury from the same risk factors, smoking, high sugar, high pressure, tend to advance roughly twice as fast as they did in your 30s. That is one reason physicians become more direct about prevention as patients move through their 40s and 50s. Now the most practical part. What do you actually do if you have experienced even one of those 5 warning episodes? even if it lasted under 10 minutes and then disappeared completely. You have roughly 72 hours where action can still prevent a full-blown stroke. The goal is not to panic. The goal is to not waste the window. Stroke specialists consistently emphasize the importance of not being completely alone in the period after a suspected transient attack. If another serious episode strikes and you suddenly cannot speak or move one side of your body, you need someone nearby who can see what is happening. Call emergency services immediately and stay with you. If you live alone, this is a conversation worth having right now with a family member or close friend. Make sure someone can reach you easily over the next couple of days after any such episode. Driving yourself is also something guidelines advise against after a possible TIA. Losing control of your vision or your arm for even a few seconds at highway speed is life-threatening for you and for every other person on that road. Talk ahead of time with your doctor about what transportation plan makes sense in your situation so you are not tempted to just get behind the wheel. If you or someone nearby can measure blood pressure and the upper number, the systolic, is around 180 or higher, and the lower number, the diastolic, is around 110 or higher, that fits the picture of a hypertensive crisis, not simply elevated blood pressure. A crisis of that magnitude is itself a strong warning for stroke, and calling emergency services right away is what standard guidelines recommend. Ask your doctor explicitly about this threshold so you know in advance when to treat a reading as an emergency. One rule from stroke medicine is absolute. Never begin blood-thinning medications on your own based on something a friend told you or something you read online. Aspirin, anticoagulants, and similar drugs can help in certain ischemic situations but can accelerate and worsen bleeding in a hemorrhagic stroke. No physician can determine which type of stroke is occurring without brain imaging, typically a CT scan in a hospital. The right move is to get evaluated and let a medical team make that call. While waiting for help or on the way to care, body position matters. Lying flat is generally better than sitting upright because it supports blood flow to the brain. Many clinicians suggest a comfortable flat position with the legs slightly elevated above chest level. Keep the head in a neutral position, not bent sharply forward, not thrown back, so that the neck vessels are not kinked or compressed. Now, even if 72 hours pass without a new episode, that does not mean you are in the clear. It means you were given a second chance. Use it. There are 3 evaluations worth asking your doctor about specifically if you have experienced any of these warning signs. The first is a specialized neck artery ultrasound called carotid duplex imaging. Unlike a basic ultrasound that only shows anatomy, duplex imaging shows both the structure of the artery and how blood is actually moving through it, including whether flow is becoming turbulent and accelerated at a narrowed segment. If the carotid artery is narrowed by more than roughly 70% by plaque, that is called hemodynamically significant stenosis, meaning the narrowing is severe enough to seriously impair flow. At that point, surgeons may discuss a procedure called carotid endarterectomy, where the artery is opened and the plaque removed. It sounds major, but in modern practice it is a routine surgery that prevents tens of thousands of strokes every year. The second test is a blood marker called glycated hemoglobin, or HbA1c. This measures how much of your oxygen-carrying hemoglobin has had sugar molecules attached to it over the past 3 months. The higher your blood sugar has been over that period, the higher the result. You cannot game this test with one perfect fasting day before the blood draw. A reading under 5.7% is normal, 5.7 to 6.4% is prediabetes, and 6.5% or higher typically meets the criteria for diabetes. This test is especially valuable for catching that gray zone where blood sugar has been high enough long enough to injure vessels, but no one has labeled it diabetes yet. The third investigation is Holter monitoring. Instead of the 10 or 20-second electrocardiogram done in a clinic, a Holter monitor records your heart rhythm continuously for 24 hours while you go about your normal day. The reason this matters is that some dangerous heart rhythm problems come and go. They may appear once or twice a day for only a few seconds and be completely invisible on a short snapshot ECG. The most important rhythm to detect is atrial fibrillation, or a fib. In a fib, the upper chambers of the heart stop beating in an organized way and instead quiver chaotically, sometimes at rates of 300 to 400 contractions per minute. Blood does not empty smoothly, it churns and swirls, and in that swirling blood, clots form readily. Those clots can exit the heart, travel to the brain, and lodge in an artery. This is called a cardioembolic stroke, and it tends to be severe. Many people with a fib feel little to nothing beyond an occasional flutter they blame on stress or caffeine. When a fib is identified and treated with anticoagulant medications that are properly monitored, stroke risk in this condition drops by roughly 60 to 70%. That is not a fixed outcome. That is a modifiable risk. Let me bring this full circle. Stroke is not a bolt of lightning from a clear sky. It is a predictable event that follows years of quiet vessel damage, and it almost always announces itself in advance. You now know the 5 signals: brief blindness in one eye, sudden one-sided numbness or tingling, abrupt loss of coordination or balance, a sudden serious breakdown in speech, and the combination of vitiligo with new unusual headaches. Any of these appearing for the first time, even if they vanish within minutes, is a reason to speak to a doctor urgently and specifically request those 3 evaluations: carotid duplex ultrasound, glycated hemoglobin, and Holter ECG monitoring. On the prevention side, keeping blood sugar in a healthy range and catching prediabetes early protects the endothelium and slows plaque progression. Managing blood pressure carefully with your doctor's guidance, avoiding both extremes, reduces strain on your vessels and lowers both hemorrhagic and ischemic risk. And stopping smoking, with support if you need it, removes a constant chemical assault on your arteries and cuts ischemic stroke risk by a factor of 2 to 4 over time. Do not wait for brief brain symptoms to go away by themselves. In the stroke world, 72 hours is the window. Use it. Here is your action step after this video. If you recognized any of those 5 warning signs from your own experience, even from months ago, write them down in plain language right now and bring that list to your next doctor's appointment. Do not rely on memory. Ask directly whether you should be evaluated for transient ischemic attacks, and ask specifically whether carotid duplex ultrasound, glycated hemoglobin testing, or Holter monitoring makes sense in your case. If you have risk factors like high blood sugar, high blood pressure, smoking, or an autoimmune condition, use what you learned here to have a more specific, more productive conversation with your physician, rather than walking away with everything looks fine and no actual data. Everything covered in this video is for educational purposes. Your individual situation is specific to you, and using this as a starting point for a real conversation with your doctor will always be more valuable than trying to manage anything on your own. If this made a complicated topic easier to understand, subscribe and tap the bell icon so you catch every new video the moment it goes live. This kind of content takes real work to make, and your subscription is what makes it possible to keep going. Drop a comment below and let me know what you thought, and more importantly, tell me what topic you want me to cover next. I read every suggestion, and the next video topic may come directly from what you write right now. Thank you for watching, and I will see you in the next one.